My name is Greg Warren, and I'm president of DHIC, and I want to welcome you all to the first of two events that we're holding today to mark DHIC's 40th anniversary. We are very pleased that you can join us here today, and as we explore the relationships between healthy, stable housing and positive health outcomes for residents who live in such housing and such neighborhoods. This day, we are fortunate to have a number of different sponsors that have helped to underwrite this event. And first and foremost, I'd like to recognize NeighborWorks America as the presenting sponsor. NeighborWorks America is a national nonprofit, congressionally chartered group that provides training, technical assistance, and even, yes, some grant money to DHIC, which we're very fortunate to receive. We're one of 230 organizations across the nation that are charter members of NeighborWorks America. Also, as gold sponsors, I'd like to recognize KHEC, Community Affordable Housing Equity Corporation, that invests in many of our developments that we undertake. First Tennessee Bank, Harold K. Jordan & Company, a builder that we have a long-standing relationship with, as well as J. Davis Architects, architects of many of our different developments. A healthy environment means healthier people, and healthier people need fewer public resources to pursue and maintain happy, productive lives and families. So say a wealth of research now circulating between community developers, funders, and public stakeholders who are interested in the specific link between accessible, affordable housing and health outcomes. Now, there's a lot of talk about all of that connection, but that's really what we want to do here today, is to learn more about what we've been doing in the realm of healthy housing. And at DHIC, we're proud to feel that we've made some good efforts to start out with promoting healthy living in our housing. Early on, we developed supportive housing, permanent supportive housing for single men and women coming out of recovery programs, shelters, or maybe just boarding houses. Lennox Chase Apartments provided permanent housing, studio apartments for those single men and women. UNC School of Social Work did a study about the cost that those individuals were the cost to support those individuals pre and post occupancy at Lennox Chase, and found that there was a savings of roughly 25% of the cost of support prior to, before folks moved in and after. Their medical costs went down, cost of incarceration, legal issues went down, mental health services went down, and the like. So we know that stable housing is a touchstone for many folks in recovery and those with disabilities. We also have been a market leader in producing LEED certified housing. We have 4 different developments in the Triangle that have received either LEED Gold or Silver designations. And for those of you familiar with LEED type of practices, many of you think that it's very energy efficient housing, which it is. Great deal of focus on that. But it also, there's a strong emphasis on indoor air quality, making sure that we don't have off-gassing of any materials in those houses and the like. So we feel that we've been trying our best to move in that direction as well. I'd also note that we really built our first smoke-free campus, not just smoke-free buildings, at Water Garden in North Raleigh, and we were really pleased with how that's turned out. So without any further comment, I would like to introduce our first speaker is David Jacobs. David is from the National Center for Healthy Housing, and it's a preeminent nonprofit dedicated to creating safe and healthy housing. He's a veteran of the U.S. Department of Housing and Urban Development, where he focused on the Healthy Homes initiatives of HUD. And he is an expert that I think we will find very interesting in his presentation. And later on, after his presentation, we will convene a town hall style meeting, which Bill Rowe from UNC Chapel Hill will moderate. So without further ado, please join me in welcoming David Jacobs. Thank you, David. Now, we have that.
Okay.
I think that works.
I hope so. Well, good morning. It's a pleasure to be here to participate in a very important conversation, which I hope we can have. And it's a little difficult to be described as a veteran of HUD. I feel like I should show you my battle scars or something, but that's another story. So what I want to do this morning is sort of lay the groundwork for our town hall meeting by painting some policy dilemmas that continue to face us today. Broadly speaking, if you think about it, what's the two biggest sectors of our economy that are in crisis? It's housing, the affordable housing crisis, and healthcare reform, right? And we're struggling as a nation to figure out what to do about both of them. They're obviously interconnected, but the connections between the two are not really adequately considered. So let me see here. Where do I point this? There. Okay, so housing and health are connected in multiple ways. We know that housing quality matters in the physical sense because it promotes durability. Affordability is essential part of the equation because people should not be faced with the prospect of making their rent payment or getting their meds for that month. And sometimes low-income folks do that. We know that the house is not just a physical entity, but it exists in a community and a neighborhood. So there are neighborhood factors that are at play, as well as the physical neighborhood. Wrong way. So this impacts both physical health and mental health. It turns out the Europeans have actually done a lot more research work than we have on the mental health aspect of housing quality, but we've seen that as well in a number of them. 40% of U.S. homes in big cities have at least one health and safety hazard in them. That's incredible, right? 40%. That's huge. This idea that housing and health are connected is not really a new one. Florence Nightingale, well over a century, had the observation that housing and health are one of the most important connections for the population. And this is sort of a picture of miasma. You know what miasma is? Who knows? Anybody? Yeah, go ahead. Bad smells, right? And this is before we had the germ theory of disease. But the idea was bad smells in certain neighborhoods stalked in the neighborhoods of the poor and were responsible for increased diseases. And frankly, if we didn't have, most of our health laws, our housing laws, are associated with public health problems, typhoid, tuberculosis, and cholera, well over a century ago. Those diseases are now largely eradicated in this country, in part due to better medicine, but also due to a housing intervention that we all take for granted now, which was indoor plumbing. Indoor plumbing. That had a lot to do with the sanitation movement. Back in those days, housing and health were joined at the hip in promoting sanitation. So the challenge of those three diseases seemed insurmountable at the time, but the lessons for public health and housing professionals was that if you provide fresh air into these units, in fact, if you ever go to New York City, go to the Tenement Museum, and if you go on a certain tour, you can see something called Typhoid Windows. And these are basically windows on the interior of units, which basically allow the air to move into the units and promote better ventilation. Reducing crowding, improving sanitation. As I said, those diseases were largely eradicated. Now, this is a picture of the Cuyahoga River in my hometown of Cleveland back in the 60s. And it caught on fire not once, not twice, but several times. So this is why we have the Clean Air and the Clean Water Act. People basically said, wait a minute, we breathe that air and we drink that water. We need to act together to make sure that that doesn't happen again. So the question is housing part of that shared commons? Most of our environmental and public health laws are based on this idea that there are shared commons. So this is one definition. It's everywhere: air we breathe, words we speak, traditions we respect, tangible and intangible, local and global, everything we inherit together. But then here's the kicker. Look at the last sentence. It's everything that is not privately or state-owned. Well, most housing in this country is privately owned, right? So that would suggest that housing is not part of our shared commons. Now, you need to look no further than the mortgage crisis to realize that, well, wait a minute, housing is, in fact, part of our shared commons. But this has had the consequence of fragmenting the way in which we regulate and promote housing. It's kind of up to each jurisdiction to figure out which standards they're going to comply with and so forth. So If you're rehabbing a home, it's probably going to depend on your local requirements. If you have an appendectomy in Seattle or in Raleigh, you hope it gets done the same way, right? That's not really, we don't have that sort of commonality approach to housing, but we need it. So here's our policy dilemma. If you look at it narrowly from a financial perspective, it makes no sense to make a health investment in housing because the market typically doesn't recognize that health investment. So if you put a new roof or a new furnace on your home, when it comes time to sell that home, the appraiser is going to come in and he'll recognize that you have a new roof or a new furnace and the value of that house will go up. It'll be reflected in the market price. If you make a health investment, like an asthma-friendly home, or a lead-abated home or something like that, the market can't fully recognize that yet. So we're stuck with trying to find market vehicles to help the market recognize that, in fact, these investments make sense and will save us money. We're stuck right now kind of in articulating the cost of what it means to make a house, well, of not making homes healthy, which is huge, and I'll show you some of the data in a minute. Whoop. So fundamentally what Healthy Homes is about is reestablishing this connection that we had 100 years ago. There's a good historical piece to be written that would sort of look at why did those two worlds diverge? In some ways, the public health world became more medically oriented. This is in the 20s and 30s. And they said, we'll treat you, but only after you get sick. And the housing world became sort of more financial and architecturally driven. And it really wasn't until the 70s and the 80s, and in the 90s, I suppose, where the lead problem reappeared, and people realized you have to reconnect those two worlds. You can't have rehab guys trying to interpret blood lead data, and you can't have doctors trying to figure out how to rehab houses. Neither world is trained to do that, so they have to talk to each other. So these are some of the players. You can probably think of many others, but trying to reestablish this connection between the built environment and health is absolutely essential. We have the figure from CDC is still have, despite enormous progress, 350,000 children each year who are poisoned from lead, primarily from lead-based paint. 18,000 injury deaths each year. If you exclude automobile accidents, the home is the second leading location for those deaths. 21,000 lung cancer due to radon is the second leading cause of lung cancer, and it's almost entirely a housing problem. 450 deaths and 15,000 ER visits due to carbon monoxide poisoning, and well over 2 million asthma-related emergency room visits. So in 2009, the US Surgeon General released this call to action. And for those of you not in the public health world, this is a big deal, right? This is, in 1960, the Surgeon General issued a call to action on tobacco, and that's really what launched the whole, anti-smoking campaign. So the hope is that this call to action will serve to help reconnect these two worlds in a viable way that makes sense. We know that this is probably not news to many of you, but there remain tremendous housing disparities. These are houses with, the red line is moderate, and the yellow line is severe physical hazards, and you can see that the prevalence is higher among non-Hispanic blacks compared to Hispanics and non-Hispanic whites.